Good afternoon. My name is Maureen Marcella, and I would like to thank you for joining us for our third New England QIN-QIO Healthcare Associated Infection Collaborative Webinar. Sorry for the noise, it's that heat here going on and off. I apologize. Before we get started, I want to go through a few quick housekeeping items. The audience, please take note that the presenter has no conflict of interest regarding this presentation. This webinar will be recorded and will be available within a few business days on our website. I'll provide you with the details on accessing and recording at the end of the webinar. The phone lines will be on mute for the duration of this presentation. We will take questions at the end, and I will provide you with instructions on how to unmute your line at that time. Now, to introduce our speaker. Dr. Lynn McNicoll is a medical graduate of McGill University and completed her residency in internal medicine at Northwestern University in Chicago. After completing a fellowship in geriatric medicine and clinical epidemiology at Yale University in 2002, Dr. McNicoll joined the faculty of medicine at the Warren Albert Medical School of Brown University. She is now an associate professor of medicine. At Brown, she has won several awards for her implementation of geriatric-friendly programs at the Mariam Hospital. She specializes in quality improvement initiatives in hospital setting and improving care for hospitalized elder patients. She is Director of Education for the Division of Geriatrics and oversees most geriatric education programs for the residents and medical students at Brown. She is also the Director of Quality Management and Outcomes for the Department of Medicine and Director of Scholarly Concentration Program overall, as well as the Scholarly Concentration in Aging. She has been a consultant here at Health Centric Advisors, the Quality Improvement Organization for Rhode Island, since 2014, specifically in hospital and nursing home related matters. She was on the leadership team for the Rhode Island ICU Collaborative from 2005 to 2013. She has been the medical director at 2 nursing homes and has been caring for patients in all settings, including nursing homes, for the past 13 years. Please let me welcome Dr. McNicoll. The floor is yours, Dr. McNicoll.
Thank you, Maureen. Welcome, everyone, and thank you for the invitation to speak to you today on CUSP for HAI. As Maureen said, I'm a geriatrician. I focus on hospital and nursing home quality improvement. And I've been actually working at Health Centric since 2004. I'm proud to have been part of many great collaboratives with Maureen and others here at Health Centric Advisors. So I'm going to try to keep this to about 40 minutes, 45 minutes maybe, and I'd love to have some opportunities to have some discussion with you guys at the end. So if there's an idea or a thought that comes to mind as I'm speaking, please write it down or enter it in the chat room that Maureen is going to be monitoring, and so that we can have a discussion at the end. I am sure that many of you have worked on CUSP over the years or similar types of initiatives, and what we'd like to hear are your ideas and your thoughts about it. I'm a geriatrician. I led the ICU Collaborative, but I don't work in an ICU, and I've not directly been in the weeds for all of these. So I'm sure many of you have a lot more experience and ideas that we'd love to hear about. And that's the entire part of being a part of a collaborative, is that we share ideas. So I'd like to start with an inspirational video. Let's see if this works. if they can do it, why can't we? And a lot of what we deal with in culture safety is about working together as a team. So I'd like to make a note for all of you to please try to access the ARC website if you haven't already. As listed here, they have lots of information and toolkits, a lot of it coming from the Armstrong Institute for Peace and Safety and Quality. And of course, on the CUSP, Stop HAI, and in particular on the CUSP, Stop ESI, and Stop CAUTI are great resources for people. As well as the the Department of Defense website, which is also another option to use for improving culture safety. So these are my objectives for today, and we'll try to cover all of these. When I do a talk, I like to see what's going on in the literature overall as to how many articles are being published on this topic. So I did just an avid search on safety culture articles over the last 3.5 decades. And as you can see, we've gone from 1,000 articles per decade to over 3,000 articles per decade. And in the last 5 years or so, we've almost already reached the 3,000 article threshold from the last decade. So, for example, you'd have to read 41 articles per month just to keep in touch with safety culture. And that's not very feasible in our day-to-day life. But somebody's done that for us to an extent. Weaver et al. And colleagues reviewed many of them for us, 3,679. It's a systematic review that is published in the Annals of Internal Medicine. And out of all these, only 162 required full review. And of these, only 33 were included in the analysis of this study. Which makes me wonder about the quality of these 3,700 articles. Among the 33, 8 of them had multifaceted interventions, which, as you know, makes it hard to determine what part of the intervention was the most effective. But 20 included team training and communication tools, and 8 included executive walk-rounds. Of the 33, 29 showed significant improvement in either safety culture or in outcomes. The limitations that were noted in the systematic review is that the strength of the evidence was very low, or low, I should say, and most studies are pre- and post-evaluations of low to moderate quality. Now, none of these are what we would consider robust scientific studies. They're not randomized placebo-controlled trials for the most part, and the evidence only suggests that interventions can improve perceptions of safety culture and potentially reduce safety harm. So the message here is that we still have a long way to go in terms of the science of safety, especially in terms of safety culture. But you know, every one of us who's worked in a hospital, in a nursing home, and outpatient practice, in healthcare, knows that culture is tremendously important in improving outcomes and improving the quality of life of the people who work there and teamwork. So we know that it's important, but we haven't figured out how to prove it yet scientifically. So let's talk a bit about HAIs and CUSP. Again, there is validity that CUSP can improve many of the components of HAIs. We know intuitively that HAIs occur in many ways because the culture in the institution is impaired. And we can't have an HAI initiative without improving the culture within that unit. So CUSP is traditionally been implemented and studied in the ICU, and the literature is most supportive of that, and especially with catheter-related bloodstream infections, partly because it's such a great, it's an easy enough outcome to measure, and there's little controversy as to how to measure it, as there is with VAC and even catheter-associated UTIs. But it still doesn't mean that we can't do it outside of the ICU. It makes it a little bit more difficult because we know HAI occur outside of the ICU. You can have central lines outside of the ICU. You can have surgical site infections and, of course, catheter-related UTI. The other aspect between ICUs and medical surgical units is that the team is not always well-defined in those units. In the ICUs, traditionally, especially with closed ICUs, it's much more clear to have a physician champion, a nurse champion, and dedicated rehab specialists that are part of the team. On a medical surgical unit, it's not always that clear-cut. And it makes it more difficult to do team-based culture improvement. So let's talk about CUSP as one strategy to help the culture of safety for aging. I'd like to start with a polling question. So I'm hoping that the polling question will show up, and it does. Has your hospital participated in any of the following CUSP initiatives? So if you can enter your answer, and please press submit at the bottom on the right-hand side of the screen. Have you participated in the ICU, on the CUSP PSI, on the CUSP CAUTI, 2 or more of the above, or none of the above? Please proceed. Okay. All right. So we have most of you not submitting. I'm not sure if that was a timing issue, but we'll try to do it better the next time. So let's see. The very few, most of those who submitted said none of the above. So this will be useful, hopefully. Okay, so I'd like to share our HAI data here in Rhode Island. These are publicly available data on the CDC website. I chose Rhode Island, so I didn't have to pick on any other state. However, you can all look them up yourself, so I'm not sharing any state secrets here, although we have plenty of them in Rhode Island. Mostly what you're looking at is trying to find green downgoing arrows and a few red upgoing arrows. We have a few of both. And the green and the red are statistically significant changes, good and bad. So the first column is the state 2012 compared to 2013. The states compared to the 2013 national numbers, the state compared to the national baseline. And as you can see, we still have a room for improvement. Even though several of our SIRs are below 1, we still have a few that are above 1. So we have some ways to go. I would like to comment that I looked at every of the states, and most of the states looked about the same, with some greens and some reds, except for New Hampshire. And I'd like to send a shout out to New Hampshire because they have a huge amount of greens and no reds. So whatever you're doing in New Hampshire, we'd love to hear about it. If we can comment, anybody from New Hampshire can comment on why you think you're doing so well. We'd love to hear about it. So what are the foundational elements of CUSP? It's important to note that it's not individual blame in CUSP. It's focusing on systems. It's valuing communication and teamwork. It's emphasizing infrastructure and support of that infrastructure, which is IT support, systems changes. It also asks that you accept responsibility for the systems in which you work in. And I think that what that means is even though there might be limitations to the system, you can't just blame the system for issues. You have to be able to work within that and do whatever you can to compensate for the limitations of the system. Recognizing that culture is local, that you can't, even within an institution, going from the ICU to the medical surge floor, the same tactics or tools or system changes might not be applicable. So you have to really individualize the strategy to the unit that you're dealing with. And respect transparency, and others, of course, appreciate transparency within an institution. The 4E principle, we learned this from Johns Hopkins when we started our ICU collaborative in 2005, and we've used the 4E's in many of our initiatives and quality improvement projects. And I'd like to share them with you. This engage, educate, execute, and evaluate. Engage means getting people to really come to the table and appreciate the importance of the issue that you're trying to come up with. So stories of patients that have suffered from C. diff or VAP, or I should say VA or BSI, and how they suffered from that and how important it is for us to make every effort to prevent these. Also showing baseline and benchmarking data. It's always good to compare yourself to others. The mantra that, we are different and we are unique and we have different patients and there's sicker patients and there are older patients doesn't jive so much anymore. We do have some basic risk adjustments in many of our analyses. It's what the SIR is all about. Although it's not perfect, it's important for us to know where we stand. Educate, we'll talk about that when we talk about the science of safety, trying to educate the staff on evidence. Execute is what exactly are you going to do to improve quality. I don't know how many times I've been in projects where people are just measuring and collecting information and educating and expecting things to change. It doesn't work that way. You have to do something about it. You have to create a standardized protocol, order sets. For example, the slowly removal protocol for catheter-associated UTI. You have to create an independent checklist, such as the BSI checklist. You have to empower providers that they're not going to be criticized or fired if they stop the line during either a central line insertion where they've seen a contamination occur, or some other process where you need to make sure that the cleaning lady can let people know when the ventilator lines aren't properly inserted or for other things. And then learning from your mistakes, which we'll talk about a lot in future slides. And then evaluate, provide updated and accurate results, and do analyses of these deficits. And it's an iterative process that we'll talk about. How does CUSP contribute to a safety culture of safety? It's designed again to improve the safety culture and help staff learn from mistakes, not blame them about these things, integrate safety practices into daily work. So it has to become habit. It can't be something that they do intermittently here and there. It has to become a routine part of their care. Provide scalable interventions. Again, they can be implemented throughout the hospital or the organization, although they need to be organized individualized within each unit. And what you want is to get frontline staff to participate in the process and get their ideas and their wisdom on how to fix the hazards that occur in the hospital. And it creates an environment where people and staff are willing to speak up. And that's ideally what you want as a good culture of safety. So these are the 6 components of a comprehensive unit-based safety program, and I'll go through each one of them individually. So step 1 is to evaluate your culture. It's getting increasingly difficult to do that, but what we did in the ICU Collaborative was use the Safety Attitudes Questionnaire. And we had, by the way, a statewide ICU Collaborative, so we had all of our ICUs involved, and we were sharing data so we could compare ourselves and to the state. There are tools that help evaluate the domains of culture of safety. Many people refer to them as assessing safety climate. which is defined as a shared perception or attitude about the norms, policies, and procedures related to patient safety in a snapshot in time. So, for example, we had one hospital do a safety attitudes questionnaire in the midst of a nursing strike. Well, at that point in time, the culture of safety was not great in that institution. If we had done it 2 months earlier or 2 months earlier, it might have been quite different. But you have to remember that it's a snapshot in time. The Safety Attitudes Questionnaire is one of the tools. Many are now using the ARC Hospital Survey on Patient Safety Culture, primarily because it is free. And it's similar to the SAT. We did do analysis of that, and it's very useful. I think the Safety Attitudes Questionnaire group provided us with a lot more information and detail, but we can get just as much from the ARC survey, I believe. And what you're able to do is measure, create action plans for addressing weak areas, and then remeasure, if not annually, then biannually. Let me share some of our Rhode Island IQ Collaborative data. So we started in 2005, and the last time that we measured with the Safety Attitudes Questionnaire was in 2010. And as you can see here, in 4 of the domains, teamwork, climate, safety climate, job satisfaction, and professions of management, we were able to go from a very low baseline to being out of the danger zone as a state overall. And so certainly there were people who were above the gold zone, and there were people still below the danger zone in terms of hospitals. But overall, we did a great job at improving, and then we were able to show some sustainability in those improvements in 2010. Afterwards, we pretty much had the state converted to the ARC survey. So I'd like to do a second polling question. Is your hospital currently administering any type of safety climate survey? Are you performing the Safety Attitudes Questionnaire, or some sort of homegrown, none, or you do not know? Please enter your answer now. As a reminder, please click Submit at the bottom of the right-hand side of your screen. I'm just waiting for the results to pop up. Any minute, second. Okay, so we have more people being able to answer. Thank you very much. And the vast majority are doing the ARC survey and a few homegrown. And that's very useful. Thank you so much for answering that question. So step 2 is understanding the science of safety. If you don't know about the Josie King story, please look her up. And Sorrel King was one of our speakers at one of our IQ collaboratives, and we had the pleasure of meeting her. She founded the Josie King Foundation and was the inspiration for the Johns Hopkins Armstrong Safety Institute and Peter Cronovo's work throughout the years. Josie King was a young girl who passed away after a burn, and what appeared to be misunderstandings and a group of nurses and doctors who weren't quite listening to the mother who was desperately trying to save her daughter. The original video of Sorrel King speaking for the first time about this is available on YouTube, and the Josie King Foundation website is also very useful with information if you choose to go look there. It's the video can be shared. When we did our IQ Collaborative, we had everybody just view the video and then have a discussion afterwards about what they saw and what they heard, and could that have happened at their institution. And invariably, yes, those things can happen at any of our institutions, and in many cases have, and we all know about this. So the other aspect of science of safety is that people understand that safety is a property of systems, that they understand some of the principles of safe design, how important it is to have standardization, how important it is to have independent checks, and to review and learn from your mistakes, which is another step on how exactly to do that. Also to understand that teams make wise decisions with diverse and independent input, and to avoid the blame culture that can permeate sometimes within units. And then to recognize that principles of safe design apply to both technical and teamwork, and to speak up when you have concerns, but also to listen when others speak up. This is more important than we all know. Step 3 is to establish a team. So you can't get a lot of this going unless you really have a team in place. And it has to be at the unit level. You want mostly engaged and passionate members, but you also may want to include some of your biggest critics, the harder people to change and improve, because you might actually convert them, and they might be able to be your most passionate speakers. These are some of the essential elements of a CUSP team. The senior hospital executive is very important, and we'll talk about their role with executive walk-arounds. If you're lucky enough to have a CUSP coach, that would be great. You need somebody from quality. You need a great nurse manager, maybe some frontline staff, and a physician champion. Now, obviously, that will depend if you're in the ICU or surgical unit, a medical unit, and that person needs to be able to speak and be respected by the other physicians within that unit. So they need to have the credibility of that unit. You don't want a hospitalist on a mainly surgical unit, and you want a surgeon, if you're in a surgical unit, that got the ear and the respect of his colleagues. So it's a tricky thing to get and to choose. Step 4 is implementing teamwork tools and communication. There are many. These are all available on the CUSP website. And I'll go through some of these in a little bit of detail. The daily goals and what needs to be done when the patient is ready for discharge. These are sheets or tools that you can use. It also asks, what is the patient's greatest safety risk today? What can we do to reduce the risk? And can any tube blinds or drains be removed? That's actually a question that I ask myself on any patient that's in the hospital. This is an example. You can get examples on the website very easily. But again, it goes through many of these issues that you can tick off and say, I thought about this today. And these are some of the things that are very important, like getting out of bed, doing pulmonary toilet, ambulation, that unless you have a checklist, you might forget. That's the geriatrician in me talking. AM briefing and another is having a morning meeting between the physician champion and the charge nurse. That would be wonderful to have on a daily basis, but it's good to sort of touch base and discuss what happened during the evening, who's being admitted and discharged today, what are the potential risks during the day, how can we reduce those risks, are there equipment problems, staffing problems, provider skill mix issues, and then if there are any issues coming up, then to assign somebody to follow up on those issues and take responsibility for it. Shadowing is a great way of improving the attitudes of one profession towards another. And really you want to, for example, a nurse to follow a doctor, or a doctor to follow a nurse, or a therapist, or a CNA, God forbid. That would be wonderful. But to have them follow just for a couple of hours during the day, and just to see what's happening with that person. What kind of struggles do they have? What kind of challenges do they encounter? How do they overcome them? And how are people treating them? And do they feel respected? And then you want to think about it at the end and discuss it with the team, how you're viewing their role differently now that you've walked in their shoes. There's also a shadowing process questionnaire that you can review. Were there any healthcare providers that were difficult to approach? Did one provider get approached more because they're just nice and they don't bark back at you? Did you observe any errors, either in transcription or in interpretation? And were patient problems identified quickly? The culture debriefing tool is a great way. We used to call it the FAQ action plan. What you want to do is pick an area that is you're poor or you're performing poorly, convene a group to discuss the item and develop a plan. So these are supposed to be very informal. You're not there to grill them on what they did right or wrong. You want to do active listening and guide the discussion, but not necessarily run the meeting. And there are debriefing tools, and this is one example where you would ask, what does the statement mean to you? How accurately does the score reflect your experience? Do you agree with it, disagree with it? How would it look if 100% of caregivers responded to agree strongly with this item? What would we need to do and see for it to occur? And then have an actionable item to improve the results on that unit. And this is our results that we published a few years back, looking at 2000-2008 results within the state of Rhode Island. And we had about half of the plans, half of the units that did significant work on FAQ action plans, and the other half that did not. And they really didn't do the culture debriefing tool at all. And what we were able to see is that the units that did FAQ action plans had marked improvements in many of the domains, and only one decline in working conditions, whereas the units that had no action plan declined in most of the domains. And similarly, when you looked at the patient outcomes, the BSI and back breaks decreased significantly in the units that had action plans, but even went up for VAP in the units that did not. Step 5 is identifying defects. This is something that you can pick up in any day. If you had, you asked staff on a unit, what could go wrong today on a patient, and then many of them would be able to identify issues. How will the next patient be harmed, and what can we do to prevent that harm? And there's an identifying defects tool. You can also use event reporting systems if a patient complains or a sensible event, near misses, or what surveillance team refers to as good catches, and use the results from your culture surveys to identify defects. And what you want to do is go through with the learning from defects tool, and it asks, what happened or what could happen, why did it happen, and there are always likely several factors among any of these, whether it's patient, task, provider, team, training, IT-related. Our institution is going through EPIC training. I'm sure we'll have some of these IT-related issues. Local factors, as I said, is there a strike going on that might be affecting the care, or institutional. How will you reduce the likelihood of this defect happening? I'm going to skip this for a minute because we're going to go to executive partnership. The goal is to bridge the gap between senior management and frontline staff. So it's really important that the senior executives have a role in the team that you're building. So identify one person that's going to be your contact and is going to come and be part of the team. They don't have to come to every meeting, but they should be an essential part of the team and be your executive champion. Their role is also to encourage discussions, to help remove barriers. Sometimes that's financial, sometimes that's not, sometimes that's just getting the construction crews in there and doing something differently with the architecture. Sometimes it's other things. And implement improvements. What you want to do is make sure that the frontline providers are aware that the senior executive is coming because they don't want to freak out when the CEO shows up on the unit. but you want to make sure that they understand why they're there and to be open to discussion. You want the staff to be coming up with input and sharing those ideas that we know they have and they know about it. Executive walk-arounds, we gave a seminar to all of the senior executives a few years back about how to do proper executive walk-arounds, and these are some of the questions that we thought were most useful. Can you think of any incidents or adverse events that happened in the past few days that have resulted in prolonged hospitalization for patients? Can you think of patients we have harmed as a result of problems with how we deliver care? What could leadership do to support you in providing safe patient care? And what changes could be made in this unit to promote patient safety more consistently? So just asking these questions and being open as an executive to hearing the answer is really important. So some CUSP lessons learned. As a reminder, culture is local. You need to implement in a few units, adapt, and then spread. But even as you spread, you might need to change and modify. Include the frontline staff as much as possible. They need to have representation and, not just nursing, but nursing assistants, therapists, pharmacists, people that can be very valuable to the team. It isn't a linear process. You just don't go from A to B to C and it's done. It's an iterative cycle. So similar to the PDSA cycle, you need to really go back, figure out have you done it right? Do we need to do it differently? Is it working for our unit? And improving culture takes time. I showed you the slides from 2005 to 2009. It took us 4 years to get improvement and to get above the danger zone as a state in Rhode Island. So things don't change overnight. People need to have to learn how to integrate many of these concepts, and they can't do all of it at the same time. So you need to have them do step by step so that over time they've implemented all the tools and all the checklists and all the science, but they can't do it all tomorrow. A couple of things you want to couple it with clinical focus. So we're not just doing this to make the team better, but by making the team work better and improving the culture, we will have better outcomes for our patients. A catalyst or a lubricant. The 7 Spreadly Sins of CUSP implementation, which I stole this slide from Johns Hopkins. You don't want to start with large projects. You want to start with a small unit or a medium-sized unit and then spread. Finding one person willing to do it all, yes, that is a deadly sin for all quality improvement projects. It can't be relied only on one person. Expect vigilance and hard work to solve a problem, yet always a recipe for disaster. And if a pilot project works, then spread it unchanged. As I mentioned earlier, that doesn't always work. Requiring the person and team who drove the pilot project to be responsible for system-wide spread, that can't work either. You can't expect the ICU unit team to be running a CUSP project on a medical surgical unit. It doesn't work that way. They can mentor the other units, but they can't run it for them. And look at the process and outcomes measures quarterly or more frequently if possible. That would be great. I mean, we don't want to be doing it quarterly. We want to be doing it more frequently. We don't want to be also having data that is completely outdated. And expect marked improvement in outcomes early and without attention to process. Again, that's another deadly sin that you don't want to have with these patients, with these projects. It takes time to get improvements in both CUSP and in terms of clinical outcomes, and you can't give up, and you have to persevere. How can we, as a New England QIN-QIO, support hospitals? Well, we want you to use us as well as each other as a resource. We can't do it alone. This is a collaborative. It's the nature of the collaborative. to share and to spread ideas so that other people don't have to reinvent the wheel every time for each of these. And that's why we enjoy using the ARC website, because it has a lot of tools in there that you should take advantage of. Many members have done versions of CUSP or Teams tests, and we hope that we can learn from you at the end of this, at the end of my talk. We will be providing HAI data quarterly. This isn't the most updated data we know. It's from CMS and CDC, but we'll be providing the data that we can in as best form that we can. And Blake is great at doing that. And we will continue to provide regional webinars, and what we'd like to hear from you is which topic area you would like to hear about and where you would like us to focus. So CUSP components are fairly straightforward. I mean, this isn't rocket science, but it is difficult to implement. It's harder than you can think, and it's going to be even harder in non-IT settings where the team is not well defined, especially in terms of physician members. So introducing the science of safety and some of the tools are doable. You have to do it one at a time, and you just have to have a plan of how you're going to do that. Really get an executive champion that's going to be part of the team that's going to be, you want them engaged early and often. Do not let them fall off the radar and let them stop coming to the units. And please remember that it's an ongoing challenge that even our ICU collaborative units are continuing to try to focus on. So we just have two polling questions that we'd like to ask you. If you can enter what state you are from, any of those, and please enter it now and press submit. There's another 10 seconds to go. You can enter. Thank you. And next question is, how many people are watching on your computer or login information? So we just wanted a sense of how many people are in the room with you. Because we know how many people are logged in, so we don't know how many people are actually listening in. There you go. That's popping up now. We're just trialing these questions so that we can have a better sense of how we're providing your service. As soon as that is done, I'm going to ask Maureen for some questions. Maureen is going to tell you how to unmute your line so that you can ask a question. Here we go. So there's a fair number of people who have lots of people in the room.
Okay, great. Nice to know. Okay. Thank you very much. It was a wonderful presentation. At this time, we will take a few questions. Right now, there are no questions in the chat other than from Greg, who says in New Hampshire, they selected hospitals in New Hampshire to participate in there were selected hospitals in New Hampshire that participated in CUSP to stop BSI, and all hospitals participated in the Partnership for Patients. So the largest 24 of the 26 hospitals did not engage in CUSP CAUTI. So CAUTI was a primary focus among the HACs, and the state worked with Mohammed Fakway, I think that might be right, I may be pronouncing that wrong, from Ascension Systems. So they were able to do something collaboratively to get this done, like we did in Rhode Island, I think.
Great.
That was New Hampshire. When you asked the question, how come there?
And Greg, we welcome if you want to come on the line and expand on that. That would be great too. And then
I'm sorry. I went a little hesitant. If you would like to ask a question, simply press *6 on your phone to unmute your line, and you will be unmuted.
Yeah, that's wonderful that you've used the Partnership for Patients as well as CUSP. That's great. We did this in Rhode Island, and we had great results. And also, we were able to publish a lot of our work. And, we welcome people to try to do some of they're doing good work, that they also publish some of that, if they haven't done so already, to add to the 3,000 articles in the last 3 years. Any questions? Anybody online who's had some challenges that they'd like to share, or how they've overcome some of their challenges with CUSP?
Questions?
Okay.
I guess they have it under control.
It was perfectly clear.
It was very clear, and I think they have everything under control. We will say that there is some new data. We're using some new NHSN definitions now, and so we wait for that first quarter of data to come out of NHSN, since we have now moved from just solely ICUs, and now we will be moving into the non-ICUs. I have heard anecdotally that the data is not as good as it was because of opening up stuff. Even though the denominator got larger, the rates have increased a piece. So we're very excited. It should be. We're almost to the time that first quarter of data should be in NHSN. The rule of thumb is 30 days after the close of the quarter. So hopefully by mid-May we'll have some better data to share with everybody. And that is the presentation in May reports and what Blake and his analytic group will be able to give to us. So that's a little plug for May 26th. It was a great discussion. Thanks so much for coming and presenting, Lynn. And I just have a few more announcements. When you close out this program, this particular program that we just presented does come with one CEU. So as soon as you close out, I believe an evaluation is going to pop up. So those of you that have multiple people in the room, in a day or so, a brief evaluation will be, actually I think I was told tomorrow, you will get the evaluation in your email. Once you complete that, and submit it, we will be able to know who submitted them, and as long as you fill in your name and your email address, we will be able to send you your CEU, and that will be electronically in the mail. Let's see if there's anything else. And I just said the invitation for the webinar for May 26th will be coming out soon. And that also, I want to let you know that if you're looking, the email tomorrow will also have a link to the recording and the slides. Or if you really want the slides before that, you can go to our website, which is www.healthcarefornewengland.org. And I think with that all said, I want to thank everybody again for participating. I want to thank Lynn for being a great presenter for us, and give you back a few minutes of your day. So thanks a lot, everybody, and have a great day. Bye-bye. Hang on. There's no questions.